Hi, my name is Amir Minerbi. I'm a family physician and a resident in the Rambam Institute of Pain. And what we are going to do in this last talk of this myofascial pain course is talk about building a comprehensive treatment plan for a patient with myofascial pain. Now let's take this patient. She's 72 years old and she's had low back pain for many years. And it's basically mechanical pain, meaning that it's aggravated by activity and it's alleviated by rest and by heating and massage maybe. And she's tried everything as by now she's already desperate. When we do a physical examination, we don't find anything very surprising. We find that her lumbar erectors and that her quadratus lumborum are shortened, the range of motion is limited, maybe they are tender to palpation, and no further significant findings that we can mention. And we decide that she has myofascial pain of her lumbar erectors and of her quadratus lumborum, and it's chronic myofascial pain. So what can we offer her? What can we offer this patient and patients like this one? In order to build an effective treatment plan, we have to bear in mind the pathophysiology of myofascial pain, and especially chronic myofascial pain, because there's usually a perpetuating, like a vicious cycle with perpetuating factors that cause this problem to go on and not to heal spontaneously. And this vicious cycle is usually manifested by weakness of the muscles, which are constantly contracted, which leads to pain and to avoidance of activity, which leads to further weakness of the muscles. This can be perpetuated by perpetuating factors like mechanical factors, psychosocial factors, and metabolic factors, which we'll go into in more detail in a short while. So in order for our treatment plan to be effective, we have to take care of all the stops or all the stations, if you want, in this vicious cycle, and not neglect also the perpetuating factors, because otherwise we may treat the patient, lead to improvement of her pain, and then the perpetuating factors will draw it back into the pain circle. So the first thing that we would like to do is to treat the weakness. We would like to strengthen the muscles so that they can bear and take the loads that are expected to take. The second thing will be to do some cognitive rehabilitation. Here we would like to allow the patient to go back to activity, to active life. And then we would like to have some kind of manual therapy which aims to alleviate the pain and to elongate the muscle, to alleviate the contraction of the muscles. And of course, we would like to address the perpetuating factors, because otherwise we won't be able to get out of the vicious cycle. So let's see how we do it. The first thing is muscle strengthening. So here our goal is to treat the muscle weakness. And this weakness can be relative weakness or absolute weakness, which is something that we sometimes have to discern, because relative weakness is a condition in which the muscles are basically fine. They're fine, but the load that the patient puts on his muscles or on her muscles is excessive. And this means that the muscles can't take that load. Let's say that our muscles are fine, but we bend over to lift a very heavy box, or that we go and run a marathon when we're not trained to do that. This can lead to a very high load on the muscles, and they will be relatively weak for the task that we are assigning them. Absolute muscle weakness is more easy to understand. These are really weak muscles. Let's say a patient has been lying in bed for several months because of some illness or an operation or something like that. Their muscles will waste over time, and they will be absolutely weak. So even when they try to do even daily activities like getting out of bed or bending to lift a piece of paper off the floor, this can cause the muscles to be overloaded. So weakness can be either relative or absolute. Which kind of activity can we offer our patients? Well, there's not really convincing evidence that one activity is better than another, but we usually are inclined to offer aerobic activity as a first line and leave resistance training for a later phase of the recovery plan. And within the aerobic exercises, there's no really advantage to a specific activity. We usually offer the patients walking because it's cheap, it's very available everywhere. Activity in water can be very efficacious, so swimming or even just walking in water, but also cycling and other kinds of aerobic exercise. So how long should the patient exercise and how often should they do it? We aim for daily exercise. We want to be able to build a treatment plan that allows the patients to exercise daily or at least almost daily. And the duration of the exercise should increase gradually, because if we let a patient begin with a very long exercise plan, they'll probably not be able to comply with it because they'll be in a lot of pain. We'll be loading the already loaded muscles that they have. Another important point is some patients usually sometimes tell us that, well, I don't need to really do walking because I walk a lot on my job. And it appears that it's not true, because dedicated activity is more effective than activity that's done by the way on the job or when going to the supermarket. And it's not just more effective, it also has a very important message to the patient that we expect them to take an active role in their recovery. So we insist on dedicated activity, which is daily or almost daily. Now, when we offer a patient a treatment plan or an exercise program, we usually encounter two very different kinds of patients and of challenges. The first one, the most common one, is the couch potato. Couch potato is not really used to doing anything. So we'll typically find absolute muscle weakness there, and we would like the training program to be very, very gradual, because otherwise they will just not be able to comply with them. It may even aggravate their pain. And we should base our treatment plan on a therapeutic agreement, because the patient will have to take active part of their recovery here. And if they don't do that, then probably everything that we'll do will be ineffective or effective for very short periods of time. And I usually ask the patients to fill in an exercise diary, and I review this diary on every visit, and I give feedback on the exercise that the patient was able to do, even if it's not daily, even if it's just once a week and then twice a week or 3 times a week. It's better than doing nothing, and it's somewhere where we can start and grow from there. The other kind of challenge, very different kind of challenge, is the sports addict. These are patients that usually walk during the week in an office, but during the weekend they become very brave athletes. They decide to run for very long distances or cycle for very long distances and strenuous courses, and their muscles are usually fine, but the load that they put on these muscles is excessive, and this is what we call relative muscle weakness. So these are typically weakened trainers, and our goal here is to neutralize physical activity, which here may become a perpetuating factor, because if a person does not do activity regularly and does it let's say once every very long time, then activity itself may become a perpetuating factor. And what we would like to do is to decrease the intensity and the duration of each exercise and increase the frequency of exercises. So we would tell them probably to try to exercise every day, but for shorter duration and lower intensity of each exercise. What's about the evidence on sports, on exercise as treatment for myofascial pain? Then it may come as a surprise to hear that physical activity has very little, very modest effect on pain level. But when we think about it, we didn't send the patient to exercise in order to alleviate their pain, right? We want to be able to strengthen the muscles in order to prevent the next episode. And when we look into that, it appears that physical therapy and exercise therapy, physical activity is very effective in preventing recurrence of, in this case, low back pain, but also other kinds of myofascial pain. So it does not directly affect pain, but it will affect the chance of recurrence. Let's go on to cognitive rehabilitation. It's a very important point and a very important part of the treatment plan. Our goal here is to allow the patient to gradually go back to an active life. Because as we said, pain leads many patients to inactivity, to avoid activity. Here we want to allow the patient to regain his activity. Our enemies here are the negative thinking patterns that develop and the false beliefs that develop. We've heard a little bit about that in previous lectures, but to give some examples, catastrophic thinking is very common among patients with chronic pain. Something like, my back's a wreck, I'm never going to get better. And we should note that we as the medical community have many times a responsibility for this kind of thinking. I remember one patient once told me that she wants to see an orthopedic surgeon, and he was looking at the MRI scan, and he looked at her very sadly, and he said, "Well, I'm really surprised that you can still stand up." And these kinds of remarks are a fuel in the engine of the catastrophic thinking, and we should take advantage of of the patient visits in order to reframe these thinking and to change them for the better. Another pattern of negative thinking is seeing the glass half empty. I can no longer do this, I can no longer do that, and it's something that we can definitely work on. And pessimistic predictions. It's my age, I'm not going to get any better, and it's something that we can address as well, because it's simply not true. Another problem is conditioning. Many pain patients have this kind of conditioning. Each time I go for a walk, I regret it because then it's more painful. And this is why I can't go to work, this is why I can't go to play bridge, this is why I can't get out to throw the garbage or play with the kids. And this kind of conditioning is something that we should address as well. So what are our tools during our visit? Every visit is a very good opportunity to do some CBT, some cognitive behavioral therapy. And we have to take advantage of this opportunity because during our visit, during the patient visit, we have the opportunity not only to interact verbally, but also to interact non-verbally. One example that I usually give is the limited significance of imaging tests. The first thing a patient would do when he or she enters the office is give me the discs of the MRI or of the CT scan that they've done. And the first thing that I will do is put them aside and say that, well, I'll be very interested in looking into these, but I'm more interested in listening to you and in examining you. And this gives them the message that whatever is found in these tests, which is usually degenerative changes or disc herniations or stuff like that, that we know that are very often not really well correlated with pain is not very important. It's not as important as they think it is. The back is not a wreck. The other thing that we can do is that when we examine a patient, we can emphasize the positive or the normal findings in the physical exam. So if we do a neurological examination, we can note that there is no problem with the nerves coming out from the back, going to the legs, etc. This is very reassuring for a patient who believes that their back is a mess. And then we can reframe the situation and maybe deliver the expectation, our expectations from a treatment plan. And by this way, we can empower the patient. We'll say something like maybe, well, our treatments are going to make you feel better for a while, but it's really your activity that is going to heal you. And this is a very important message for patients. It also encourages them to take an active role in the treatment plan. Let's talk about manual therapy. Here we aim to reduce pain and to improve the range of motion of the shortened muscles that are involved in myofascial pain. What are our options? Our options are, we have many options. We have dry needling, we have physical therapy, we have massage therapy, we have chiropractic treatment and osteopathic treatment. And well, if you look at the evidence, they are all equally effective, more or less. There's no convincing evidence that one is much more effective than others. And the choice should be made both by the preference of the patient and by the availability of therapists that are found in the area. How do you assess the efficacy of a manual treatment? Well, improvement is usually expected after a few treatments, no more than 4 or 5 treatments. And if we don't see that kind of improvement, then, well, maybe we should consider changing modality. But we should tell the patient that it's possible that the function will improve before pain improves. It's an important note that they should know. Maybe they'll be able to walk for a longer distance. Maybe they'll be able to walk better than before, and maybe just later pain will improve. So what about the efficacy of manual modalities? All modalities have been shown to be somewhat efficacious, but usually not on their own, but rather as a part of a comprehensive treatment plan. And we should remember also that in addition to any specific value that any of these treatments may have, they also have the important points of allowing human touch, human contacts with touching the patient is very important as a healing process. They allow us the feeling, the patient, they allow the patient the feeling that something is done in order to make them feel better. And it's an opportunity for us, the therapeutic visit is an opportunity for us to do some CBT, like we talked about before. We also will recommend to the patients to use some self-treatment methods that they can do at home. This is very important, not only because it helps them to alleviate their pain, but also because it gives them the sensation that they control their pain, which is very important. So we can suggest stretch exercise, which are very easy to find on the net, massage therapy by even family members, local cooling or heating of the affected muscles, and trigger point compression. They can use their own fingers in order to compress trigger points that are found within the involved muscles if they are accessible. And they can also use TENS, which is electrical stimulation of the skin, which many times can help in chronic myofascial pain. And last but not least is neutralizing perpetuating factors, because if we don't do that, then the patient will go back to having pain and will be back at square one. So perpetuating factors we saw are divided to three categories. The first being mechanical, which is further subdivided into structural mechanical perpetuating factors, which can be something like scoliosis, leg length discrepancy, vertebral fractures in the elderly, osteoarthritis, which is a very stubborn perpetuating factor, and even operations or surgery like lumbar fixation and other. And they can be postural or functional mechanical factors like carrying a very heavy bag on one shoulder or putting the wallet in the back pocket of the trousers. They can have to do with our working environment like ergonomics, where we put our computer, how we put our hands on the keyboard, where we put our screen, and factors like these. Very importantly, we should remember that psychosocial factors play a critical role in perpetuating pain. Not only myofascial pain, but many kinds of pain. And myofascial pain is very common, and that's why we see psychosocial issues in many patients with myofascial pain. So the common problems that we may encounter are depression, anxiety, stress, anger, and litigation. Litigation is a very powerful perpetuating factor. Litigation, lawyers, trials. What can we do about it? We can suggest psychotherapy, we can suggest biofeedback for anxiety, for stress, for anger management, and in some cases we'll also suggest pharmacotherapy, medications. Sleep disorders are sleep and pain have a very interesting interaction. Sleep disorders increase pain, pain increases, aggravates sleep disorders, so it's something that we should definitely address. And false beliefs is something that we've already discussed, should be explained, should be reframed, and should be addressed at every visit, because they are sometimes very stubborn. Metabolic perpetuating factors may be hypothyroidism, iron deficiency, vitamin B12 deficiency, and they can be treated medically. And what's important for us is to reassess on every visit. Every visit that the patient comes in, we have to reassess the status. We will ask and give feedback about the exercise program that they are implementing or not implementing. We'll do some cognitive treatment, and we will reevaluate the myofascial status and give myofascial treatment. And we'll definitely want to reassess perpetuating factors at each visit. So we've talked about this treatment plan, and there's something that we've definitely not talked about, which is medications, pharmacotherapy. How come we didn't talk about pharmacotherapy? Well, because it doesn't play a very important role in treating myofascial pain. In the acute phase, in acute myofascial pain, there's definitely an efficacy for NSAIDs, for non-steroidal anti-inflammatory drugs, which are really effective. And they can be used unless, of course, there are some compelling contraindications. But in chronic myofascial pain, which are probably most patients that we see in tertiary pain clinics, but the minority of patients that we see in primary care, we know that the efficacy of analgesics is very limited, and this includes even strong opioids, which are not effective for myofascial pain. We sometimes see cancer patients who are receiving opioids, strong opioids. The opioids are able to alleviate the cancer pain, but they are unable to alleviate myofascial pain, which is interesting. On top of that, we should remember that when we're treating chronic conditions like chronic myofascial pain, if we do decide to prescribe opioids or NSAIDs, we take a risk of side effects which may be considerable. We can use analgesics. It's not that analgesics should not be used, but they should be used intermittently and maybe only to allow for activity, to allow the patient to do their exercise plan and to go to work or to function at home. And if we did decide to give medication, we should reassess often, and if we don't see any efficacy, we should discontinue the medication. So, if we want to summarize what we offer this patient, would be probably something like a treatment plan that will include muscle strengthening using some kind of aerobic activity, cognitive rehabilitation to address the negative patterns of thinking that may be affecting and perpetuating her condition. We will want to offer manual therapy, probably dry needling, because it's very available and because it's very effective and the side effects are very rare. And we'll definitely want to look into and neutralize perpetuating factors which may be the case. So thank you very much for listening, and I wish you good luck.